Why is it so that at low doses aspirin shows antiplatelet action while at higher doses it loses this action, or it may even support the platelet activity? This entire mechanism of the aspirin was explained in 1971 for the first time by Sir John Vane, who was a British pharmacologist and also a fellow of the Royal Society of London. So let us understand this important mechanism and certain other interesting things like portal circulation, first pass metabolism, irreversible inhibition, and hit and run drugs in this interesting video. Hello friends, when we give aspirin in low doses here means 75 to 100 mg per day. So when it is absorbed by the GIT, primarily by stomach and small intestine, then first of all through portal vein it goes to the liver. And as we know that portal vein connects the GIT, that is stomach, intestine, spleen, pancreas, to the liver. Actually, this portal vein is for the protection of our body because the xenobiotics, including drugs and also the constituents of the food, should not directly go to the systemic circulation. For the safety purpose, first of all, they are sent to the liver via portal vein, and in the liver they are filtered, detoxified and metabolized in order to become compatible with and non-toxic to the systemic circulation or rest of the body tissues. So this type of metabolism in the liver is known as first pass metabolism or the pre-systemic metabolism, because all the foreign substances should not directly go to the systemic circulation. First of all, they need to be processed by liver in order to avoid any risk to the rest of the body. After this processing, they enter the systemic circulation and heart via hepatic veins. However, there are certain substances which bypass the portal circulation. For example, lipids or fats. Yes, most fats and fat-soluble vitamins are absorbed into the lymphatic system via lacteals in the intestines, bypassing the portal circulation initially. These substances enter the systemic circulation directly through the thoracic duct before eventually reaching the liver. Okay, well, so we were talking about the aspirin. Before reaching the liver, while the aspirin is in the portal vein, it meets platelets. Platelets only contain COX-1 enzyme and not the COX-2. COX-1 enzyme plays a key role in the production of thromboxane A2, which promotes platelet aggregation and clot formation. Aspirin irreversibly inhibits this COX-1 enzyme of the platelets. This inhibition is irreversible because aspirin binds to the COX-1 with strong covalent bond and does not dissociate with the enzyme. So this enzyme drug complex is excreted as such from the body. That's why this type of inhibition is also known as suicide inhibition. And so far as other NSAIDs are concerned, unlike aspirin, most other NSAIDs, for example ibuprofen, naproxen, act as reversible inhibitors of the COX enzyme. That is, they bind non-covalently and can dissociate from this enzyme, allowing this COX-1 activity to resume once the drug is cleared from the system. The irreversible inhibition of COX-1 by aspirin is particularly useful in cardiology for preventing thrombosis, while the reversible nature of other NSAIDs makes them suitable for managing pain and inflammation without the prolonged antiplatelet effect. So aspirin shows antiplatelet effect because it irreversibly inhibits COX-1 enzyme of the platelets, and platelets cannot synthesize new COX-1 enzyme because platelets lack nuclei. So this inhibition lasts for the lifespan of the platelets, that is about 7 to 10 days. Antiplatelet activity is resumed after the generation of new platelets, and it will take some time, that is 7 to 10 days. So here we can again see a very interesting phenomenon, that aspirin has been excreted from the body, but its effect still persists, that is for 7 to 10 days. This is known as hit and run effect. So aspirin is an irreversible or suicide inhibitor also, and a hit and run drug also. So after all this, aspirin ultimately reaches the liver through portal vein, and actually the aspirin is chemically acetyl salicylic acid, but it is metabolized to salicylic acid in the liver before reaching the systemic circulation. And this salicylic acid is having analgesic action, anti-inflammatory action, but it doesn't have antiplatelet action. So the antiplatelet activity is basically performed by the original aspirin, that is acetyl salicylic acid. And in contrast, at higher doses, that is 325 mg daily or more than that, all the acetyl salicylic acid can't be converted into salicylic acid. So even after the metabolism in the liver, the unmetabolized acetyl salicylic acid can reach the systemic circulation. In this case, this acetyl salicylic acid, or the original aspirin, inhibits both COX-1 and COX-2 enzymes in various tissues, including the vascular endothelium. And inhibiting this COX-2 in the endothelial cells reduces the production of prostacyclin, a molecule that normally inhibits platelet aggregation and causes vasodilation. Thus, the overall balance between prothrombotic effect because of thromboxane A2 and antithrombotic effect because of prostacyclin is altered, potentially counteracting the antiplatelet effect seen with the low doses. So here actually the reduction in the prostacyclin results in very strong pro-aggregatory outcome, and it may tip the balance towards pro-aggregation in many individuals. So at higher doses, instead of showing anti-platelet effect, aspirin may rather promote platelet aggregation. That's why for antiplatelet action, low dose of the aspirin is appropriate. And yes, it is also worth mentioning that aspirin meets the vascular endothelium of the portal vein also before reaching the liver. But since aspirin is about 150 to 200 times more potent in inhibiting the COX-1 than COX-2, it means low doses are insufficient to target the COX-2 of that vascular endothelium in the portal vein. So here we can see that at low doses, aspirin is primarily used for its antiplatelet effects, targeting the COX-1 in the platelets, while sparing COX-2, which is more involved in the inflammation. So this was all about the antiplatelet action. And if we talk about the analgesic action, so for pain relief, aspirin is usually dosed at 325 to 650 mg every 4 to 6 hours as needed. And so far as anti-inflammatory use is concerned, so in cases of inflammatory conditions such as rheumatoid arthritis, osteoarthritis, higher doses of 1000 to 3000 mg per day may be prescribed. However, it's very crucial to monitor for side effects at these higher doses, and they are usually given in divided doses throughout the day. But regarding this anti-inflammatory use, aspirin is less commonly the first choice due to the availability of more effective and better tolerated medications such as ibuprofen and naproxen, which are often preferred. So I hope that now you have completely understood about this antiplatelet action and the importance of low dose versus high dose. And soon I will be back with the next interesting video. And in case of any query, any confusion related to any chapter, any topic, you may write down your queries in the comment section, or for this purpose, I have also provided my email ID in the description box. Okay, so stay connected and soon I will be back. Thanks.